So far we've talked about how we have to have a good plan in place ahead of time. We have to be thinking as we're doing the resuscitation, what are we going to do when we get the patient back? Because that's the ultimate goal. So we can't let this turn into a goat rodeo. We have to be aggressive at doing the best critical care we can for this now living but very sick patient. So we're going to do things like be very cautious when getting an airway and establishing some sort of semi-definitive airway, or at least a reasonable airway, avoiding hypoxia, avoiding hypotension when it happens, and avoiding misplacement of the tube. So we're going to put end-tidal CO2 on the end of each one of these things. We're going to pay very attention and use a lung protective ventilation strategy to not only target our end-tidal CO2 to a reasonable level, but also to ensure that we don't cause any more lung injury than has already occurred with our bagging or with our CPR. These folks are going to have delicate lungs to start off with, and we don't want to make it worse. The best way to do that is to use reasonable vent settings and actually use a mechanical ventilator, which will be able to give you safer tidal volumes and safer pressures than you will be able to achieve with just a bag. So we're going to do that. We're going to pay attention to our hemodynamics. We're going to pay attention to our SpO2 and our end-tidal CO2, and we're not going to let them get above 99% on their SpO2 or below 92 to 94. And then we're going to watch our end-tidal as well, again, to avoid hypercarbia or hypocarbia, I guess would be the way to say that, as a result of hyper or hypoventilation. And then we're going to watch our blood pressure and pulse rate and maintain perfusion. And if that means starting a little bit of peripheral vasopressor, we'll do that. We could do some dobutamine. Probably in this day and age, what we're actually moving more towards is going to be something like push dose epi. And again, see the end of the last video if you want to know how to do a basic push dose epi. Quick calculation, quick make that up in the back of the ambulance. And then we talked about how we're going to try to mitigate all the stuff that happens afterwards. So if cooling is the thing that your protocol has, then we can still attempt pre-hospital cooling, although using 2 liters of ice cold saline probably isn't the best way to do it anymore. If cooling's in place, we'll continue to use that. There may be some evidence that comes up later on about things like steroids or other means to prevent the post-cardiac arrest syndrome, that systemic inflammation. Now, we've talked about all that stuff that's sort of specific to cardiac arrest management. We got to talk about actually treating the cause of the cardiac arrest, because if you don't treat that initial antecedent event, then there's a good chance it's going to turn right back around and kill the patient no matter what you do anyway. So sometimes it's real clear what's going on. If you find the rock on the patient's head, well, okay, that was probably a TBI. Maybe not always, but most likely. If you find the hot dog in the guy's throat and you pull it out and he suddenly oxygenates better and you get ROSC, okay, that was probably the antecedent cause. But unfortunately, a lot of the time we're not really able to tell. So I've written this more than once on a notification of death that we have to fill out. Oftentimes it's not clear to us in the emergency department what's happened, and it's probably not clear to you in the field. Again, sometimes maybe, but even the stuff that seems fairly clear-cut often isn't. So you can use the H's and T's like you learn in ACLS class, and that sort of covers things, but I'll agree with Cliff Reed in that I don't think these are very good mnemonics for them. They don't really tell you anything, and they also don't really tell you how to treat the patient himself. To borrow Cliff's thing, there are basically 3 causes of cardiac arrest: volume loss, pump failure, and obstruction. And of obstruction, there are 3 causes: tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. And those are the reasons that people die. Everything falls into those categories otherwise in one way or another. The good news is that a lot of this can be sorted out relatively quickly. Unfortunately, you have to go to the ultrasound guys to sort of learn how to do that, and I think that ultrasound is within the scope of most EMS providers, or at least most paramedics in the United States, with some additional training. It's something that you can do. Now, at least as much as we in the emergency department can do some basic ultrasonography, but you have to be asking specific questions, and you have to really know what you're going for. So for instance, you could use a RUSH exam, which stands for, if you haven't seen it, Rapid Ultrasound in Hypotension Exam. This works for a lot of the reasons that somebody might go into cardiac arrest as well. This is relatively straightforward, and if you've done any kind of the POCUS stuff, you'll kind of know what I'm talking about here. But kind of starting from the top down, or you can do it in any direction you want, we basically are going to do an ultrasound of both lungs to look for a tension pneumothorax and make sure there's good sliding. We are going to do a basic cardiac ultrasound to look for large pericardial effusion and tamponade, but also basic, is the heart squeezing like this, or is it just kind of like fluttering like this, to get a basic idea. Again, real simple, not advanced echocardiography, but real basic kind of stuff. We're going to look in the belly and do a fast exam, just like you might do in trauma, but we're looking for free fluid and other clues that the patient might be hypovolemic. We're going to look in the right upper quadrant, the left upper quadrant. Eventually, we're going to look down in the pelvis, and we should look at the IVC. The idea behind the IVC ultrasound is that if the inferior vena cava is really big and fat, and when you breathe for the patient or when the patient takes a breath, if there's no collapse of it, that means that the issue is probably not hypovolemia. If the IVC is squished down and totally small and collapses 100% every time, well, you might say, okay, well, maybe hypovolemia or maybe some sort of distributive shock is the answer. We're going to look at the aorta for signs of an aortic catastrophe, like you probably won't see dissection, although you might, but abdominal aortic aneurysm is the big one that we usually look at there, and then round it out again, looking for fluid in the pelvis, signs of hemorrhage or hypovolemia, or the clues that might lead you to why the patient went into arrest. So once you do that, you've addressed volume loss for the large part. If you can't see the hemorrhage someplace and they don't have an obvious femur that they're bleeding into, you'll be able to look in the abdomen, look for the other big sources of hemorrhage. We can look for signs of obstruction, like tension pneumothorax, and pretty well rule that out. We can look for tamponade and pretty well rule that out. We can look for signs of PE, like a big distended right ventricle, which you may be able to see. We can at least get an idea about that. So pretty well, we've evaluated for volume loss. We've evaluated for the three main causes of obstruction that we're going to find or that we might want to be aware of. The only thing left is pump failure. And again, we can sort of address it. We can sort of look at the movement of the heart, even if we're not, diagnostic echocardiographers, and making a formal distinction on it. When we look at the LV, and again, I'm just sort of saying I can tell the difference between this heart that looks like it is beating and has a lot of motion to it versus this one down at the bottom that doesn't really appear to be moving at all. Most of us can tell that difference. Now, I couldn't tell you if there's a wall motion abnormality, and I think that's outside the emergency medicine scope, and I think that's well outside most of the paramedic scope out there. There's probably people that can figure it out, but I can say whether or not I think it is squeezing or whether or not I think it's just kind of sitting there flickering, which may tell us about pump failure. The one at the bottom, again, does not appear to be pumping a lot of blood, whereas the one at the top appears relatively vigorous. There's probably blood getting out of there. Outside of using echo or basic ultrasound to address that question of is there pump failure or not, what most of us are probably going to be relying on is the 12-lead EKG. And with that, we've pretty well identified most of the reasons somebody will go into cardiac arrest. Now, the EKG is super important, of course, and this should be one of the first things after you obtain a set of vital signs that you do after you get the patient back. Why? Because if you find something on there, you're probably going to have to act on it quickly, and you're going to have to mobilize a bunch of people to make it actually happen. So you need to get that stuff rolling ahead of time because you still probably have a limited amount of time to get this stuff done and have a good outcome on the patient. Now, the big thing that we use the EKG for, at least what people think about in post ROSC care, is this STEMI or not? And I'm going to talk about that in just a second. But don't forget that there's a lot of other information you can glean from the EKG. For instance, is patient in third-degree heart block? Do they need paced? Is this a wide, complex rhythm that looks like a sine wave where now we're concerned about hyperkalemia when maybe we weren't before? Is there a toxic cause for this? Do they have that big terminal R wave that suggests that maybe this is a TCA overdose and they need a bunch of bicarb? All that is potentially out there. So don't forget that you can find other things other than ischemia on the 12-lead, and that's going to be really important. But the use of the 12-lead itself, the primary driver in terms of system stuff is probably going to be, do we see things that look like STEMI? You get a 12-lead. If you get this, you can be pretty sure that something's going on. If you get one EKG that shows STEMI morphology in your post ROSC patient, the chance that the patient has a coronary lesion that needs to be intervened on is about 90%. So some people will say, oh, that's ST elevation, that's just their post-cardiac arrest thing, that doesn't mean anything. Well, there's about a 90% chance that it actually does mean something. It means that they need to go to the cath lab and get that opened up. So anybody that even gets one post ROSC EKG that's consistent with STEMI or meets STEMI criteria, again, 90% chance they've got something that needs an intervention, they should go to the cath lab. So treat all these patients as cath lab patients. Activate the cath lab ahead of time. Take the cardiologist and the emergency physician out of it and just say, this is a pre-hospital STEMI. They were arrested. Now they're not arrested. We need to open the cath lab for them. That's cool. If they have this, then they need to go here. And that is fairly well established, and most people will roll along with that for the most part, although we'll see again in a minute about some of the perils and challenges of it. What happens, though, if you don't get that? If you don't get that EKG, you get this EKG. Just sort of non-specific changes, looks like sinus rhythm, maybe they're tachycardic, something like that, but nothing nothing to really hang your hat on, nothing that's screaming, this is a left coronary occlusion or something like that, or RCA. What do you do with those guys? Unfortunately, our ability, and this has become more prevalent as you probably have read recently if you're up on any of the stuff that comes through like phone or social media, STEMI does not necessarily equate to occlusive myocardial infarction, and occlusive myocardial infarction does not necessarily present as a STEMI. So if you see this in your post ROSC patient, nonspecific changes, no STEMI on EKG, there is still about a 33% chance that they have some sort of obstructive coronary lesion that probably needs intervened on. So about a third of the folks that come back, even if they don't have STEMI on their EKG, will have something that they need to go to the cath lab for. And we found, and that's a large number. You may say, oh, well, if you play the odds, 2/3 people don't. Well, we do stuff for like 10% of people all the time. The 33% is a pretty big number. What that basically says to me, and I think to a lot of us in the pre-hospital field and in emergency medicine, is that probably most of these guys need to go to the cath lab and get their coronaries at least looked at, if not intervened on. And in fact, this is a list of some of the studies that show if you have an aggressive strategy, if your center takes people to the cath lab early, regardless of whether they have STEMI on their EKG or not, if you take them up there early after ROSC, they do better. And again, this is just a list of those studies. I won't belabor them. How much better? Odds ratio for good neurological survivors about 1.9 times. So if you're aggressive, patients do better. Whether or not they had a stentable lesion or whatever, if you went someplace where they took you up to the cath lab, you did better overall. Unfortunately, though, the path from the field and through the ER and then to the cath lab is beset on all sides with danger and with scary things, and there's a lot of twists and turns, and you may get separated from your group and have to go a different direction. Part of the reason of that is the cardiology guys themselves, and I'm trying not to rail a whole lot and say like, that damn cardiologist, because they are, I think, in the end, trying to do what they think is best for the patient. But to us, we sort of have different thoughts about them, I think, sometimes. So as an example, this is the post-cardiac arrest algorithm for who should go to the cath lab from the American College of Cardiology. This is essentially the guidelines set out by the Professional Society for Cardiologists. What do you do with somebody when they come in after cardiac arrest and now they have a pulse back? I will tell you that you'll see the first shot across the bow comes in the very opening paragraphs of this thing, where it says, the role of first responders, emergency room doctors, and non-cardiologists focuses on the process rather than the appropriateness of the cath lab activation. Ouch, man, I'm standing right here, and you said it anyway. And they go on to say, although many patients have improved outcomes with early invasive approach, just like I said, some patient subsets may not derive a benefit and may experience excess risk. From the pre-hospital standpoint and from the ED standpoint, it is true that most of us are focused on the idea of we've got this system in place. If we stick with the system, we tune the system so that patients do better if they go through the system. So again, 1.9 times better odds ratio if you went someplace that got the early cath lab approach. The cardiologists, however, are saying, well, that may mean we take some patients up there that don't benefit from it. And that's true. But then also they may experience excess risk. And when you cath patients electively all the time, I don't know what sort of excess risk. Maybe they have a chance they could have a coronary perforation or something like that, but that's pretty small risk in the person that has a 33% chance of still having an occlusive myocardial infarction, in my opinion. That said, this is what they say, so let's roll with it for just a second. You may notice that sometimes you bring a patient into the ER and they go straight up to the cath lab. Sometimes you bring them in and they sit in the ED and they never make it to the cath lab, even though it could be potentially the same patient intervention or same patient population. Here is what this algorithm says. To boil it down, it says if you have ST segment elevation on an EKG, then this is probably a STEMI. We should activate the cath lab, and we should probably take this patient up for emergency angiography. If you don't have a STEMI, you should still consider taking them to the cath lab, assess them, think whether or not they probably have a coronary occlusion or not, and at some point they should get an early intervention. Now, early is sort of a relative term. Does that mean within 24 hours? Probably what we're thinking of. Maybe within 48 or 72 hours is what some folks will stretch it out to. But those folks should probably go to the cath lab as well. Okay. Reasonable. STEMI, yes. Emergency cath lab, wake them up. Non-STEMI, okay. Let's let them sit in the ICU. We'll take them to the lab first thing in the morning. Seems reasonable. Unfortunately, there's a part in the middle of all that may seem somewhat dangerous to some of us in that it lets us out of doing what we think is probably best for the patient. What is that? Well, it's this big black box that was in the middle that both paths lead to. And it says, if the patient has any of these unfavorable resuscitation factors, or some of them, then maybe they shouldn't go up to the cath lab and they're not likely to benefit from it. Now, that part is actually not based on an evidence-based statement. If you look at these things up here, they say, well, who are the patients with unfavorable resuscitation factors? Well, they have unwitnessed arrest, non-VF, non-shockable rhythm, no CPR, long resuscitation times, if they're still getting CPR in the ED, if they're a little bit acidotic, if their lactate's a little high. By the way, this is not very acidotic and not very high lactate. Or if they're old or have need dialysis, or if you think they died from something else. All right, I'll buy that one. But all this other stuff in here, these aren't markers of necessarily who's going to benefit from a coronary intervention. These are markers of how likely the patient is to die overall. Now, we don't know if the cath lab would actually benefit them. Studies are hopefully ongoing right now, but we don't really know which of these patients with this stuff truly wouldn't benefit from going to the cath lab. We know that they die frequently, and they're more likely to die than somebody without all this stuff. But just because you didn't get CPR and your pH is a little bit low and your lactate's a little bit high, that doesn't necessarily, in my mind, mean that you couldn't benefit from going to the cath lab. Again, I put it out there just to say this is what folks are reading. So if you see this happen, don't be surprised and don't necessarily blame the ER doc for it. What this says is patients are more likely to die with or without a cath, and we don't know which of them is actually responsible for it. Again, I will go back and make the point that as you're setting up your system, because probably your system has not talked about your post ROSC care if you're listening to this talk. You probably don't have a great system that's out there for what are we going to do when the patient comes in after cardiac arrest once we get the pulse back. These are a number of studies that show that you have better outcomes if you take them up to the cath lab early, and so I would lean on that direction. It's also important to note that you really can't prognosticate how long or how well the patient's going to do until about 72 hours out. Now, if the patient continues to go cardiac arrest and arrest and arrest and arrest over and over and over again, yeah, that patient is not likely to do well. Or if they were found down and their last known normal was an hour ago and they're cold when you get to them, yeah, that patient is probably not going to do real well. But overall, we have to have probably at least 72 hours for the patient's neurological exam to stabilize before we can determine who is really going to have a terrible outcome and who may come back. The folks in Minnesota may even say that this goes out to maybe 4 or 5 days. Probably we can't be in a hurry to make a big determination on that. Certainly not in the field or in the emergency department or in the ICU in the first couple of hours after the patient's cardiac arrest, generally speaking. So what do? I think you got to treat all these patients aggressively. If you see a STEMI, call it a STEMI. Call the cath lab, call the hospital, use the Pulsera app or whatever it is that you're going to do and get those folks rolling in so that you can start the momentum of we are going to be aggressive on this guy and see what happens. And if this is what somebody brings up to you, oh, well, his lactate's 8. Well, like I can sneeze and my lactate go up to 8. I put this out here as to say this is what you may run into as you develop your post ROSC algorithms and what you actually do with these folks. But I would encourage you from the pre-hospital side to be aggressive and treat all these patients, number one, as if they all probably have STEMI, because to some extent, a lot of them are going to. The question next becomes, all right, well, then what? And I present this not necessarily as you're going to do a whole lot in the pre-hospital setting about this, but for any of you that work needy or are just curious about what might go on afterwards in terms of treating these patients, I hand this to you now. So there's a not insignificant number of these folks that will come in with either hemorrhagic stroke as the cause of their cardiac arrest or a massive PE, which you can see on the right there, that giant dark spot in the middle of all the contrast filling the pulmonary artery. If you do a 12 lead, and this is folks that don't have an obvious, stab to the chest or something like that, or didn't have an obvious reason for their cardiac arrest. If you do a 12 lead EKG, a rush exam, that ultrasound exam that I showed you before, and then do a CT non-contrast to the head and a CT PE, this will probably identify between 60 and 80% of all the cardiac arrest etiologies out there. So just doing this basic stuff that we'll sometimes do in the emergency department will get you pretty well set. So we'll do that stuff, and we'll usually get the patient admitted. And if we have an answer, great. And then if we don't have an answer, then still okay for us, we'll still admit them to the hospital here. The question then again becomes, then what? Well, you got to wait for a while. And I kind of mentioned this before. You've probably got about 72 hours before you can make a determination about whether or not this patient's brain is actually going to recover and to what extent it's going to start to recover. Now, your full recovery, is months and months and months down the road. But in the short term, is the patient going to wake up? You probably have to wait at least 72 hours, if not more, to determine that. Sometimes it's fairly clear early on with some of our perfusion studies that we can get, but a lot of times you do have to let them sit for about 3 days or so and just see what happens. It's worth noting that 50% of the mortality after cardiac arrest comes from withdrawal of care, meaning we determine that it's futile and you pull the plug, essentially. 50% of the deaths that occur after cardiac arrest aren't the person rearresting, they are us terminating any further efforts on the patient. What am I getting at? I'm saying that we probably should be having these discussions up in the ICU when things have calmed down, when things have sort of stabilized, when you have time to talk to the family, and when you have time to get the information that you need to make an informed decision. Certainly all these folks shouldn't just be resuscitated forever, but the time to determine when we're going to cut that off is probably up in the ICU. It's not in the emergency department. It's generally not in the field unless the person has some sort of advanced directive or something like that. Now, certainly, if the family says, no, he would not want to be resuscitated, okay, stop, absolutely. No, he would never want to be intubated, even for a short period of time. Okay, stop. No, he's on hospice. Okay, stop. No, she's 94 years old and she's got terrible renal failure and she's been in asystole ever since you found her, and she would never have wanted all this to start off with. Okay, fine, great, terminate. But the 55-year-old guy who gets 20 minutes of CPR, even if they have a non-shockable rhythm, even if you think they're probably going to die, the time to determine that is 3 days down the road. It's not right now. So don't do this in the field. Don't do this in the ER. If somebody says stop, or if you've met your termination of resuscitation stuff, then stop. But once you get a pulse back, then I think we have to be aggressive about it, at least in the short term, because we don't know what's going to happen. All right, so to sum up our discussion of post ROSC care in the field, number one, you have to have a plan. You don't want the patient to wake up and see a Muppet show going on in front of them. Once they get ROSC, things get a whole lot harder than just doing the ACLS algorithm. And so you have to have really good plans ahead of time, or at least have an idea of where we're going to go and what we're going to do with these guys. So we're going to base our stuff on making the patient think that they are sedate and calm on a nice sandy beach someplace with good oxygen tension and the ability to breathe normally. Or if you don't like the nice warm sandy beach, you can say the cool forest of the Pacific Northwest, because you probably do want them to not be hot but get just a little bit cool. So good place for it. Once we make them think that through means of things like sedation and airway control, we are going to be aggressive but very cautious in maintaining a good patent airway, using end-tidal CO2 to confirm every tube every time. We're going to give drugs not only for sedation and pain control, but also to support their hemodynamics. If Levoped's available, you could do that as sort of the first line, but push-dose epi for most EMS services is probably going to be where a lot of us end up. We're going to do whatever we can to mitigate the post-cardiac arrest syndrome. So things like therapeutic temperature management. Again, not everybody has to get cold, but we don't want them to get a fever. And so if we can do, if that's in your protocol to do in the field, yes, still do it. And remember, cold is not bad. We just now say that maybe cold is not much better than cool. So if we are moving that direction, and nobody should get a fever, by the way. So if somebody has moved that direction, or if you have a protocol to start in that direction, cool is good. And then we're going to do a bunch of stuff to figure out why the patient went into cardiac arrest, namely an EKG. We can throw in ultrasound too, and if you are interested, check out the POCUS guys, and they'll be able to give you a little better idea of what's feasible and in what way for pre-hospital providers. A little plug for them. Once they get to the ER, we'll do a little bit of other stuff because there are other things that cause you to go into cardiac arrest. And in the end, remember that this book doesn't exist right now. It probably should, but it's just a little tiny chapter in the end of all the AHA recommendations. So get with your crews, get with your education support folks, get with your medical director. Figure out what it is that you're going to do and what's expected of you after the patient comes back so that you avoid that Muppet show that we talked about previously. So I may not be able to give you this manual right now, but I've hopefully given you some things to talk about. Hopefully it helps. Again, Walt Lubbers, and we'll talk to you later.